I'm going to go through what we do with fetal MRI at the Children's Hospital of Philadelphia. The major indications we have, as you see here, for the brain are anomalies, hydrocephalus, ventricular asymmetries and ventricular enlargement, destructive brain injury, vascular malformations, and occasionally a tumor. For the spine, it's deformities that are typically mostly myelomeningocele, occasionally the syrinx, and not infrequently in the caudal area of the spine, masses such as sacrococcygeal teratomas. In fetal MRI, maternal fetal safety is primary issue, and we do 18 weeks or older, not typically before that. Everything has previously had an ultrasound, which has led to the MRI imaging. We use FDA-approved pulse sequences, reducing the SAR, and everything has been approved by the IRB. We typically do our cases at 1.5 Tesla. We recently, in the last year, have been using a 3T as well, and the images are quite good, but we usually only use that on the older fetuses where there's less amniotic fluid and less artifact from the fluid. We use the phased array body coil. Typical times are 10 to 20 second acquisition, 20 to 30 minutes per examination. We do not sedate the fetus or the mother. When we do these studies for the brain, we use ultrafast or haste imaging for the T2s, about 0.5 seconds per image. Each image is without the next image, so that if motion occurs, you only destroy the image where the image patient is moving. So this would be a typical T2. And then we do T1s if indicated, and we do echoplanar imaging when further indicated, looking for hemorrhage, which is fairly routine in our practice to look for. We do diffusion imaging routinely on all of our heads, and that works quite well. We have to pay attention to the developing brain so that when we look at fetal MRIs of the brain, we're aware of the gestational age. Here we are at 18 weeks of gestation, and when we look at a brain at that stage of development, the sylvian region is wide open. There's no closure of the opercula. You have a flat or lesencephalic-looking brain. You have three layers. You have the cortex, you have the germinal matrix, and you have the cell sparsome in between where the neurons will be migrating through from the germinal matrix to form cortex. As the brain develops, we get toward 26 weeks of gestation. One can see that the sylvian fissure remains open, but it's starting to close a little bit. We look for the development of the first sulcal anatomy, maybe a middle temporal sulcus. One hasn't quite developed here yet at this point in time. And we're starting to see more of the anatomy that we associate with a more developed brain as we look at it. So we get to 32 weeks of gestation, we have more of the sulcal and gyral anatomy. That is what we're typically seeing in our neonates that are born prematurely. And we're seeing a more normally formed brain at this point in time. Now, when you look at the patient per gestational age, the imaging findings that you're going to be paying attention to are the size of the cerebral hemispheres and cerebellar hemispheres of the vermis, the sulcal development, the fissures, such as the sylvian, various clefts. You're going to be looking for irregularity of the cortex. You're going to be looking for irregularity of the ependema. You're going to look for the presence of cysts within the brain or subarachnoid space. You're going to be looking on the EPI images for bleeding. You'll pay attention to the eyes to make sure they've developed in a normal fashion. You're going to look at the lips and the palate for any clefting. And you're going to look at the septum pellucidum to make sure that that's intact. So here we have a patient with agenesis of the corpus callosum, fairly straightforward, separation of the hemispheres, colpocephaly with the occipital horns. And the question is, do we have any migrational anomalies that we can pick up at 20 weeks gestation? We don't see in this particular case any irregularity of the cortex, but we have our concerns. Here we have a slightly older, more 30-week gestational infant, and we're able to look at the surface of the brain here over the frontal lobe on the right side and see that there's irregularities that are present, and This is the beginning of polymicrogyria here. The hemisphere is slightly smaller. And here we have, at 7 days of age post-delivery, the neonate showing the polymicrogyria involving the right frontal lobe, such as you see here. This is a even older patient now in the neonatal period, showing the polymicrogyria on the right, the smaller hemisphere. And we can go back in this particular case to about 22 weeks gestation and see that that abnormality was actually visible as a smaller hemisphere and as an irregularity of the surface of the brain. Now, obviously, as the fetus gets older, and we're comparing that to what we have in the post-delivery period, the images are going to be fairly similar. Here's a 32-week fetus with hemimegalencephaly, in which we can see very nicely that the hemisphere is totally abnormal, the signal intensity is abnormal, the surface anatomy is abnormal, such as we have over here as a 4-day-old female following delivery. Here we have a 37-week fetus. We look at the surface of the brain. The sulcal anatomy is gone. We're dealing with ageria or lesioncephaly, and that's pretty straightforward on the fetal MRI. It's basically virtually the same as you would have in a newborn neonate. Looking at the margins of the ependema is an important thing to do, to look for heterotopia, as Tom has just described. The irregularity can be easily picked up, such as you see here, and such as you see here in this infant following delivery. Now, a large portion of our population is referred for ventricular enlargement, and then we have to consider the etiologies of the ventriculomegaly, whether there's brain destruction, congenital maldevelopment, and whether we have hydrocephalus that's under increased pressure due to altered CSF dynamics, such as you might have with aqueductal stenosis. The normal intraventricular pressure in a fetus is 40 to 50 millimeters of mercury. When you have hydrocephalus, the pressures are, by therapeutic cephalocentesis, 350 to 400 millimeters of mercury. What surprises us a lot of times is that the subarachnoid space in a fetus with hydrocephalus actually looks pretty good despite the ventricular enlargement. Now, hydrocephalus, aqueductal stenosis represents about 20% of the cases that we see. Mortality in 51 cases was 16%, normal cognition only 40%. Here is the enlargement of the lateral ventricles and third ventricle with the relatively small fourth ventricle. That goes along with the aqueductal stenosis as a cause for the hydrocephalus. Now, this is important for your SAM, that you pay attention, that the aqueductal stenosis in males, Becker-Adams syndrome, is about 7% of males with aqueductal stenosis. They have severe mental retardation, adduction of the thumbs, and this occurs with chromosome XQ28 and XQ27.3. They encode neural cell adhesion molecule L1. Obviously, this is a case where you're better off not having the fetus go to term. Hydrocephalus, the problems are when you have progression on serial studies. There's an increased incidence with aqueductal stenosis. A thin cortical mantle in this situation leads to an unfavorable prognosis. Here, for instance, with cortical destruction in an aqueductal stenosis cases, you can see rupture of the cortex associated with the ventriculomegaly. Here we will have the concern as to why the aqueduct is occluded. Is it developmental congenital anomaly, or is it secondary to a prior infection, or is it secondary to a blockage from blood products, such as you would have if you had a germinal matrix hemorrhage? Here in a 19-week fetus, we're going to see blood layering here in the ventricle on both sides. Here's a blood fluid level on one side, here it is on the other side. That's enough to give us an etiology for blockage of the aqueductus sylvius, secondary to intraventricular hemorrhage in utero. Now, in the hydrocephalus category of malformations of the brain, we have the Chiari-2. In a series of 43 patients imported in the literature, mortality was 23%, normal cognition 66%. We measure the size of the atria here and correlate that to the degree of hydrocephalus. Now again, for the SAMs, it's important to pay attention when we talk about myelomeningoceles. We take the patients who have no maternal risk factors, strong family support. The fetus is typically 22 to 25 weeks at time of surgery, an atrial diameter of less than 17 millimeters, normal leg motion, no club feet, no other anomalies, and a normal karyotype. And here you can see a patient with a spinal dysraphism, a low-lying lumbar sacral sac, the myelomeningocele. This is the myelomeningocele in a 20-week gestational fetus. There is a neural placode coming out into it. Here you can see it in the midline, that's the neural placode. Here is the non-skin covered myelomeningocele. This is preoperatively, where you look at the brain and you see caudalization of the cerebellum and brainstem into the upper cervical region. There's ventriculomegaly present at this point in time. This is following surgery on the lumbar region, compare of the sac, and at 30 weeks post-fetus, that is 7 weeks post-operatively, the posterior fossa structures have returned to a relatively normal position. Brainstem and cerebellum are in the posterior fossa. The tectum remains beaked, as we would have in a Chiari-II malformation. This is an image of the preoperative sac of the myelomeningocele at 27 weeks. Here is the surgical exposure of the uterus. This is the repair of the myelomeningocele done at the time of surgery back in 1989. Now, when you repair that, you correct the problems in the head and the posterior fossa. However, when you look at the post-op patient and you do the patient not only as a fetus but as a term infant, you'll find that the cord remains tethered down to the operative site. It does not go springing back up to a normal location in the spinal canal. So once tethered, they do remain in that location despite repair. The problems that we worry about are not so much in the posterior fossa, as you see here, but down in the lumbar region where the repair has been done. And at that point, we worry about the problem of an epidermoid occurring if ectodermal tissue gets included in the repair site. And here you can see on the diffusion-weighted image that there is abnormal diffusion at the site of the repair, and that's an epidermoid of the repaired site. When you do not repair the myelomeningocele in utero, and you do it in the postnatal period after delivery, there remains the caudalization of the cerebellar structures and brainstem into the upper cervical spinal canal, and all of the anomalies that Tom just talked to you about, the polygyria of the brain that is secondary to the distortion caused by the caudalization of structures. Now, in the myelomeningocele repair study at CHOP, the 50 fetuses that first had it done between 1998 and 2002, survival was 94%. The mean age at delivery was 34 weeks. All had reversal of the hindbrain herniation, better than predicted leg function, 57%. The need for a shunt was only 43% for hydrocephalus. The historic controls for shunting in this population was 85%. So there was about a 50% improvement in the need for shunting for hydrocephalus in this patient population. The mean maximum preoperative ventricular size was 11.2 millimeters. The ventriculomegaly at birth was 16.2. Shunt placement 43%. Mean age at shunting was 21.2 weeks post-delivery. Agenesis of the corpus callosum we've already started to talk about. Here's a study that came out of Boston where only ultrasound recognized on fetuses, 6 out of 20, and 20 out of 20 were recognized on fetal MRI. Basically, the coronal view and the axial view will show you agenesis of the corpus callosum on fetal MRI without issue. Now, whenever you're looking at something, as we've just pointed out, such as agenesis of the corpus callosum, you need to look not only at the brain, you need to look at the other structures, such as the facial abnormalities. And here, if you look at the orbits, you can see that the globe on the left is small, microphthalmic, relative to the globe on the right. So that's pretty straightforward. Aicardi syndrome is an X-linked dominant. It affects mainly females. Infantile spasms are present. Callosal agenesis is one of the manifestations. Heterotopia, polymicrogyria, interhemispheric cysts, choroidal retinal lacunae, choroid plexus papillomas on occasion, but quite rare. Here you can see a patient with agenesis of the corpus callosum and Aicardi syndrome with the cyst and its manifestations. Walker-Warburg phenotype, mutation of multiple genes, thick cortex, cobblestone appearance is the description of it. There are ocular anomalies in association with it, hydrocephalus, callosal hypoplasia, hypomyelination. The pontine hypoplasia gives you a kink in the pons and dysmorphic-looking cerebellum. It's an easy diagnosis if you look at the lateral sagittal image of the brainstem, where you see almost a C-shaped kink, secondary to the pontine hypoplasia. Recognizing the cobblestone appearance of the cortex is something that even with good imaging in the fetus is extremely difficult. In this case, there is cerebellar hypoplasia present as well. We've already heard about alobar holoprosencephaly with failure of division of the prosencephalon. Here you can see very nicely in a 20-week fetus that there is no midline structure. There is a monoventricle, as we see here. There is fusion of the thalmi, such as you see over here. And basically, it's a very straightforward diagnosis. With a little more division, we end up getting somewhat of two hemispheres. And this is the semilobar type of holoprosencephaly. And in the lobar holoprosencephaly, we have the interhemispheric fissure developing, a bit of Fawkes, but we still have gray matter crossing the midline, and we have two ventricles, as we can see here. This is the lobar form of holoprosencephaly. In addition to that, the patient has this thickening of the scalp and of the neck, and that's the presence of hydrops in this fetus. With 3D reconstructions, with surface imaging, with fetal MRI, one can actually picture the cleft lip much as you do with ultrasound examinations. In imaging the fetus, we have to think about the cerebellum, which is slower to develop than the cerebral hemispheres. They're disproportionately small at 20 weeks relative to the hemispheres. Ultrasound often overcalls abnormalities. We get a number of referrals every week for ruling out Dandy Walker malformation when all they have is a normal-sized cerebellum, a relatively large CSF space in the posterior fossa, and they do not have a malformation and do not need any termination. In general, in the 18 to 28 weeks of gestation, the fetal age equals millimeters for the transverse diameter of the cerebellar hemispheres. So a 20-week fetus typically has a 20 millimeter cerebellar width. Tom has already pointed out to you the problems as you look at the question of a Dandy Walker. Here we have the vermis, which has undergone or failed to undergo complete rotation. It has a relatively open appearance on the axial image, and this was once upon a time called the so-called Dandy Walker variant, that is the under-rotated vermis with a little bit of hypoplasia. Here you see an example of the right cerebellar hemisphere being hypoplastic on both the neonatal and on the fetal MRI. Dandy Walker malformation, we know, has abnormal Vermean structures. The cerebellar hemispheres themselves are hypoplastic. The posterior fossa is enlarged, high torcula. This is a 35-week fetus with cerebellar hypoplasia, Vermean hypoplasia, and the beginnings of an elevated torcula. This is a more severe example in a 28-week fetus in which there is hydrocephalus. There's a huge cyst of the posterior fossa, hardly any cerebellar hemispheres left, and a major Dandy-Walker cerebellar malformation. The brainstem is hypoplastic, as you can see. Joubert syndrome and related disorders, or the JSRDs, are a group of disorders. You have the molar tooth midbrain, high-brain malformation. It's genetic. There's a small vermis. Midbrain pons junction is thin. You have a bat-wing fourth ventricle. Superior cerebellar peduncles are large and horizontal. There's an absence of decussation of the superior cerebellar peduncles. You have a small midbrain. Here you can see very nicely the molar tooth of the brainstem. There is the fourth ventricle, which is dilated. And here are the bilateral, thick, superior cerebellar peduncles. Over here you have the 3-day-old neonate with the same identical abnormalities that were seen at 24 weeks of gestation. Encephaloceles, Tom has done a very nice job of pointing out how the tissue herniates out into the encephalocele and how the hemispheres are smaller and the brain is more microcephalic as a result of the malformation. In the suprasellar region, we see arachnoid cysts not infrequently in our fetal population. Basically, those are straightforward. As far as other masses that occur in the fetus in that region, teratomas are not infrequent. Hamartomas can be seen. We also pick up, not infrequently, giant cell tumors associated with tuberous sclerosis. We do not typically see hypothalamic astrocytomas, as those are things that develop in the neonate or infant more commonly than in the fetus. In imaging the fetus, we have to think about a variety of other things that go on. Destructive processes that affect the brain that may be confused with malformations, cortical infarctions, hypoxic ischemic brain injury, cortical rupture we've already pointed out from hydrocephalus. You can see periventricular leukomalacia, especially if it's cystic. Germinal matrix hemorrhage, as we pointed out, that can produce aqueductal occlusion. You have infections that you have to worry about, such as cytomegalovirus, metabolic diseases that can affect the brain, even in utero. Here you have cortical infarctions in 2 patients, one at 25 weeks, one at 37 weeks of gestation. This is a 16-year-old mother with a 27-week gestation, bilateral infarcts in the brain that are destructive and obviously not a good thing for the fetus to go on to term. Schizencephaly, Tom has briefly brought up. Here at 24 weeks, we have an infarct in the middle cerebral artery territory on the left. We have hemorrhagic changes on the EPI, echoplanar imaging, for blood products. And here you can see a seam on the other side, a so-called to develop closed-lip schizencephaly at the site of an area of hemorrhagic infarction. Here on the 5-week-old neonatal MRI, there's an open-lip schizencephaly on the left, and we have a closed-lip schizencephaly over here on the right, and we still have some of the blood products left on the susceptibility-weighted imaging. In the destructive process category, periventricular leukomalacia can occur in the fetus in utero. Here we have at 32 weeks, cystic changes above the lateral ventricles bilaterally. Here on the 6-week neonatal MRI, the same identical cavities above the margins of the lateral ventricles. This is a 29-week-old fetus. The mother had operative hypotension at 21 weeks of gestation, and you can see that the ventricles are somewhat large. The the cyst of the septum pellucidum is large. We have infarcts in the basal ganglia as wholes, and this is evidence of a profound asphyxic injury occurring to the fetus in utero. Evolution of germinal matrix bleeds in utero. This is a 26-week fetus at the initial evaluation. Here you have the germinal matrix hemorrhage in the margin of the left lateral ventricle. Here it is grade 4. Here 15 days later on follow-up fetal MRI, one can see the cavity that has the site of the hemorrhage has been evacuated, and we end up with what will be an area of poor encephaly within the brain. Point out that their destructive processes include a variety of malformations, including vein of Galen. Here's a 32-week fetus, which is a very straightforward diagnosis. Huge vein of Galen and straight sinus, transverse sinuses. We don't very often get the opportunity to try and do a MRA on a fetus, but here's an example that worked, where you can see the vein of Galen and the straight sinus, torcula, and transverse venous sinuses. These obviously can be huge, as in this case, where there is marked enlargement producing hydrocephalus and not infrequently ischemia with loss of tissue. This is another one example of a vein of Galen malformation, easily straightforward. To point out, we do diffusion-weighted imaging in our patients. Here you can see an area of damage to the thalamus in this patient with a vein of Galen malformation. We would attribute this to ischemia, and there is the site of infarction. Now, something that caught us by surprise, and we've now seen about a dozen of these, are these large hematoma-type signal intensity structures, most frequently in and around the torcular region, such as you have over here, if I can get my mouse to work. And basically, here you have it, the superior sagittal sinus, transverse sinus, torcula, and this is sinus venous thrombosis occurring in utero. You would think that this would be a horrible prognostic indicator, but in follow-up of the dozen or so patients we've had, the neurologist who's looking after them tells me that they're all doing well. So what are our thoughts for the future? Here's the fetus scratching his head, giving me the thumbs up. Everything's going to be good. What is it? That fetal MRI is easily performed if you have experience and have the referral population. It requires experience, not only in looking at the images, but in your technicians knowing how to do the studies and to anticipate what needs to be done as these fetuses move and change position and cause consternation. They can be challenging, but it's opening up new insights into our understanding of fetal and neonatal diseases, how things develop, and I believe that all of us, this will become a standard issue that we need to deal with. Thank you for your attention.